Welcome to the Zenlins podcast. I'm Ian Beardsall. This podcast is another in our series recorded live at the Premier Conference in Winchester in June 2024. In this episode, Anna Kyle, a consultant paediatrician from Somerset, takes us through all of the things we need to consider when assessing a young person, and that can be a young adult too, who presents with eating disorder. This is actually a much more complex condition than perhaps you might think at first, and Anna gives some really excellent advice about how to not just treat this condition, but also look after the patient and their family when you're seeing them. As always, there's a comprehensive blog post available on the website, which includes a complete transcription of the podcast and links to further information. I hope you enjoy it.
I'm going to come in straight with my take-home message, which is eating disorders are deadly. Really sadly, there's a lot of press lately, probably in the last 5 years, reporting really sad deaths of mainly young women, mainly at the transition age, and the eating disorders are deadly. We're still quoting actually anorexia nervosa as being the most deadly of all psychiatric conditions, so it's something like a 10% lifetime mortality risk if you have anorexia nervosa. And the coroners here have reported failings, medical failings, a woeful lack of knowledge. And I guess that's kind of understandable. There was a BMJ report in 2018 looking at how much training we get as undergraduates, and it's something like 2 hours in our 5 years of training in eating disorders and undergraduates. We also know that eating disorders are increasingly prevalent. There's been a 90% increase in admissions through our ED department and through our PAUs to our wards in the last 5 years. Just imagine if we'd seen a 90% increase in things like TB or measles, what a furore that would cause. They're deadly. About 1 in 5 of deaths from eating disorders are from suicide. So if my maths is correct, about 4 out of 5 of those deaths are from medical complications. So we need to know about this. It's an epidemic we need to know about. I'm going to try and take you through the assessment and management of an eating disorder in your ED, the medical complications, and some top tips. So what are you going to see? You're going to see patients presenting basically with the effects of starvation, with the effects of malnutrition, and that affects pretty much every system. You're going to see people who have not got enough nutrition and not got enough energy on board, and essentially what happens then is everything slows down. Pretty much every physiological system within your body slows down, and some actually stop. So, for instance, if we take the gastric system, I would say that pretty much 100% of the patients I see will have constipation. They'll complain of abdominal pain, they'll complain of bloating, can get a gastroparesis. And that's basically because if you haven't got enough energy coming in, things are going to start slowing down, aren't they? So the peristalsis through the gut's going to become really sluggish. So it is going to feel like when they're eating, it's just sitting there and it's just not moving through, and that's going to cause tummy pain. And it's also kind of makes sense, doesn't it? If you're not eating very much, then the gut needs as much time possible to extract all the nutrients out of that small amount of food which is going through. So constipation really common. Fertility, obviously impact of fertility hopefully is going to be transient, and that's going to be down to the secondary amenorrhea that we see. If your periods stop, that's a really clear sign that you're not eating enough and your body's not happy. Again, a really clever actually evolutionary adaptation amenorrhea. If we look at populations that have been plunged into famine, fertility generally drops across that whole population, because what's the point of bringing in another child into a population where there's not enough food to even make you healthy and to be able to support a baby. Bones. So we know that young people with low weight from not eating enough are at increased risk of low bone mineral density and at increased risk of fracture later in life. And that's because if they're not having periods, then they've got low estrogen levels, they've got low IGF-1, they've got higher cortisol because it's quite a stressful position, and that all impacts on bone turnover. We quite often see sick euthyroid syndrome. So we may see low T4 and T3 when we do bloods, but a normal TSH. Please don't start them on thyroxine. They don't need thyroxine, they just need food. Hematological, so we get the slowdown in bone marrow work, really effort of work, and we often see a neutropenia. Neutropenia is really common in people who are underweight, and it's actually quite a good way of tracking their weight. You see the upwards flick when they begin to gain weight as well, and a lot of them can be anemic. We see impact on hair and skin. Brain. So things begin to slow down, and if you've only got a certain amount of energy, your body tries to power the most important things, which essentially are heart and brain. So if you're seeing symptoms which are both cardiac or with the brain, and when I talk about the brain, I guess I'm talking about slowing of cognitions, poor concentration, then you know something's really up. So we're just going to talk a little bit more about the cardiovascular system. So bradycardia, a really obvious one that I'm sure you're all aware of. We worry about a bradycardia of under 40 in eating disorders. That's a red flag. Please don't give them atropine. What they need is food. Commonly see sinus bradycardia, but we can see heart block and we can see things like a junctional nodal escape rhythm. I've seen that a couple of times. I looked at the ECG, totally freaked out, phoned a cardiology friend. Luckily didn't need anything other than admitting and feeding and nutrition. We often see the postural tachycardia and the changes in blood pressure, but we also see pericardial effusion, and actually papers and report pericardial effusion, asymptomatic pericardial effusion, to be somewhere about a third of young adolescent girls with this. We've seen this fairly recently just in our hospital when we echoed a girl who presented with pitting edema up to mid-thigh with a refeeding. She got an echo and she had a really large pericardial effusion, 3 centimetres surrounding both the ventricles. Again, that doesn't need pericardiocentesis, it doesn't need draining, it needs food and it will settle with time. Left ventricular atrophy, again, I guess quite understandable really. If you're losing muscle bulk from the rest of your body, you're also losing muscle bulk from your biggest pumping organ. And with that left ventricular atrophy, you can see mitral valve prolapse. I've picked up a few new systolic murmurs in clinic who've gone on to have echoes and it has been mitral valve prolapse. It may be the reason that some people present with chest pain and dizziness and fatigue. Again, doesn't need surgery, needs food. That left ventricle will improve and hopefully the prolapse will improve too. So the brain basically shrinks, which is pretty significant, isn't it? And quite often I will show these images if I'm seeing a patient in an outpatient setting and I've got the time, just to show the impact of malnutrition on the brain. So basically what you're going to see in A&E is you're going to see people presenting with signs and symptoms that are attributable to starvation. So they're going to come in with a whole range of symptoms. You're either going to get a patient present who's got a known eating disorder, and that's more likely to have been brought in actually probably by worried parents, or you're going to have a patient who you don't know necessarily has got an eating disorder, and hopefully you're going to pick it up on your screening, whether that's your HEADS assessment or something called a SCOFF screening. What is your role as somebody who's working out of an emergency department? Your role is basically doing a risk assessment, and this is what you guys are all really great at. What you've got to decide is this young person well enough to go home and be discharged, or do they need to be admitted? And we've got these fantastic new guidance, MEAD guidance, Managing Medical Emergencies and Eating Disorders, which came out in about March 2022 to replace the marzipan guidance, and we can use these to try and help our risk assessment. The MEAD guidance gives us a lovely RAG rating of red, amber and green. Here are the red flags. What I find really useful is sharing the MEAD guidance and the RAG screening with the young person and with the family, because what it does actually say is for those red flags, it actually says impending risk to life. And for the amber flags, there's alert to impending risk to life. So it really hammers home the importance of us doing a really thorough examination of this young person, because this is serious illness. The main red flags that I tend to really focus on are the rapidity of the weight loss, not necessarily the BMI, although that is important, but it's the rapidity of the weight loss. The heart rate, the blood pressure, really useful. I talked a little bit about the postural tachycardia we see and the postural drop. That's also really useful to track progress. So when people are getting better, usually within about 6-7 days, you see that improve. The other thing that's really useful to try and do in your ED departments is the SUS test. So that's the sit-up, squat, stand test. It's essentially a test of their muscular function and how strong they are. Your department should have a MEAD pro forma. This is the one we've just started using just last week in Taunton. I've borrowed it and been lent it from colleagues from out of Leicester Children's Hospital. I really like it because it's really simple, it's really colourful. It basically takes the MEAD criteria and pops it into this flowchart for you with some hints of what to ask and why it's important to ask those things. I guess the things I just wanted to make you aware of is quite often young people will sit in front of you with a very normal heart rate. But when you've got somebody who's telling you that they're only eating a lettuce or a cucumber each day, that's not reassuring, and it's possibly because they're sitting in an emergency department. And if you get them onto an ECG machine and rest them, their blood pressure their heart rate will probably drop. So don't be reassured by a normal heart rate. Risk assessments are always just for a guide, and I would really want you to think about if you're going to admit this young person. And what MEAD suggests is if they've got 1 red flag or 2 ambers they need admitting, then it really ought to be a joint discussion with your CAMS colleagues if you've got them. And ideally, if they're in the hospital, have a chat with them. because it may well be that they don't tick many reds on your physical criteria, but if the parents are saying, but if I take her home and push her to eat, she's going to self-harm, or but if I push her to eat, she's throwing glasses, I'm really worried about my safety, then there may be a reason to admit them for more of a psychosocial reason as opposed to a pure physical reason. Top tips on communication. Remember the bungee jump. When a young person has a plate of food put in front of them, it is like asking them to step off a cliff every single time. 3 meals a day, 3 snacks a day. They're incredibly fearful, there's terror there, and they're in that fight and flight mode the whole time. So just remember when you're talking to these young people, you know how difficult it is to communicate and to converse and to negotiate with somebody who's in the fight and flight the whole time. You're going to have to use all your skills to try and bring them out of that before you can connect and before you can have a good chat with them. Separate the carer from the young person and separate the young person from the ED. What do I mean by this? I mean, it's always really good to see young people with their parents to get a history, but very often what I see is the young person maybe giving their history of this is how much I'm eating, no, I'm not purging, I'm not doing much exercise, and I can see their adults sitting behind them going, just cringing, because they know that that's not the truth. But many parents are not going to want to jump in and challenge their adolescent for obvious reasons. They don't want to have an angry outburst, they don't want to feel like they're undermining. So it's really important to try and talk to the parent alone too, because you're likely to get quite a different story. We know that eating disorders can be really secretive. They can be deceitful, they can be dishonest. It's the eating disorder that's doing that and not the young person, which is what I mean by separate the young person from the eating disorder. It can be really helpful to externalise the eating disorder and say, I can see that the eating disorder is making you do this, I can see that the eating disorder is really challenging you here. Really try and separate them. These young person are not manipulative. It's the eating disorder that's making that happen. In paediatrics, I think we really try to be this, keep calm and carry on, don't we? We want to appear like we really know what's going on, which hopefully we do most of the time. We want to keep the parents alert. We want to reduce the parents' anxiety. So if you've got a little chap who comes in through ED, whether he's got croup or whether he's got wheeze, we're likely to say, no problem, we're just going to pop you into resus. We're just going to pop this adrenaline mask on your face. We're just going to pop this cannula in. We've seen this before. We know what we're doing. We're just going to do some popping. The difference with an eating disorder is you're very likely to have a young person who's sitting in front of you, who's possibly been brought in by a worried teacher or parent, who's saying, there's nothing wrong with me, I feel fine, there's nothing wrong with me. I've just been to the GP and they've told me my ECG is normal and my blood's normal, I want to go home. What we need to be doing is sharing our concern really openly with this family and actually almost trying to just raise the anxiety a little bit. So we need to be explaining that normal ECGs and normal bloods aren't reassuring. Our bodies are really good at keeping everything stable and keeping everything just right. So for instance, looking at that boat, I would say to you, is that boat floating? Most of you would go, yeah. But the only reason that boat's floating is because you've got men and possibly women bailing out that water as fast as they can. I can't tell you at what point those people's arms are going to get tired and that boat is going to sink. And that's what I'd be saying to a young person. Your bloods may be okay at the moment. Your blood pressure may be okay at the moment. But I can't tell you how long it's going to take for your body to suddenly crash and to suddenly fail because you're not eating enough or you're exercising too much. You need to be steering away, actually, from minimising or trivialising the illness. Because if you say something like, well, your obs are okay today, so you don't need admitting, that's going to go one of two ways, and both ways are bad, actually. That eating disorder is going to hear, you're okay, you're not unwell, you can go home and continue what you're doing. Or even worse, it's going to hear, that doctor's just said you're well, that doctor's just said you're fat, you're not doing a good enough job of this, you need to try harder, and they're going to go home and restrict even more. So really think about your language. If you're going to be discharging someone from your department, you need to be saying, your obs are okay at the moment, this is not reassuring because of this, and this. We're going to keep a really close eye on you. We're going to check, hopefully check you again, whether that's in the community or with the GP, so that they're not hearing that they're okay. Really try and steer away from talking about weights and calories. You're going to get into this vicious cycle of lots of battles and lots of negotiations. Actually, when we admit people to our ward, I'm quite clear that we're not admitting them to achieve weight gain. Okay, what we want is we want a regular eating pattern. We want them to know how much they need to eat. We want to be able to keep them bed rested. We want to be able to help with their restricting their exercise. We want to give their parents a rest. Of course, if we get all that right, weight gain will be the end result. but really try and steer away from talking about weight and calories. What we're wanting to do is to improve their health, to improve their heart rate, to improve their blood pressure, to stop them from fainting. And we tend to try and blind weigh if we can. If they're heading towards sort of 16, 17 years, then some people will want to know their weight, and it's important to give them that, really. But always chat with the parents. If you're not sure, don't just blurt out a weight in front of them. And the last thing I just want to leave you with is steer away from any sort of blame. Okay, eating disorders are not lifestyle choices. They are not a parenting failure. Time and time again, we hear young people in these families talk about shame and talk about guilt of having a mental diagnosis in their family. They feel shameful that they're taking our time up. They repeatedly say, I don't know why you've admitted me, I don't need to be here, there's people who are far more worthy. These kids are worthy of our time. These families are worthy of our time. They're worthy of seats in our waiting room and they're worthy of beds in our wards. Please give eating disorders the same empathy and attention and compassion as you would give to any other young person, whether that's admitted with leukemia or pneumonia or DKA. Thanks.